Okay, welcome back everybody to our second part of the session on personalized health, and it's my great pleasure to introduce Dr. Adrian Egli. Adrian is the head of the clinical microbiology department here at the University Hospital of Basel. So he's really involved in clinical practice, but at the same time, he also leads one of the driver projects of SPHN, which is concerned with sepsis, and this is what he's going to present to us about today.
Thank you very much. Thank you very much for the kind introduction and also the opportunity to present here our endeavor, let's say, to form a new network in Switzerland regarding sepsis. And as you can see here from all those logos, there every Swiss university hospital and university is involved, all the intensive care units, the infectious disease divisions, and the clinical microbiologists. Together with ETH Zurich, we formed this network, and I will show you now basically the concept of our project, but we have very regular meetings already and exchange, and it gets really concrete. I will show you. So, but first of all, I think we have to understand why sepsis is so important. I don't know how many clinicians are here, but sepsis has really a profound impact. It's rather a syndrome than a particular disease. If you see patients with sepsis, basically every patient has a different phenotype. It's very heterogeneous in the clinical presentation. Nevertheless, it's a frequent problem in clinics, on ICUs, and it is associated with a substantial morbidity and mortality rates, depending on how late somebody with sepsis presents, can be up to 70 or 80%. And also there's a substantial reduction in the quality of life of survivors, so that they basically can be reintegrated into a normal life is a very difficult task. And you can imagine the associated healthcare costs with this kind of intensive care medicine is extremely expensive, not only in Switzerland where everything is expensive, but certainly around the globe, the costs associated with sepsis is substantial. Now, how is sepsis defined? So this problem I told you on the heterogeneity is somewhat reflected also in the definitions. So a while ago, sepsis 2 as a definition was introduced. That means sepsis is a proven or suspected infection with a so-called SIRS, and SIRS stands for Systemic Inflammatory Response Syndrome. So this is basically if I walk from the basement to the second floor, I have a SIRS, so my body temperature rises, I have a larger pulse rate, and you can imagine this is a very, very sensitive inclusion criteria, not very specific. Specificity is added by the infection. Now, then after a long time and many discussions, 2016, sepsis 3 was introduced, and what stayed the same is the infection part, so you need to have a proven or suspected infection, and then something was added, SOFA, and SOFA stands for Sepsis-Related Organ Failure Assessment, and that now is far less sensitive, but much, much more specific, because it allows you to predict mortality. You have every organ system, so the lung function is integrated, mental scores, cardiac function, liver function, kidney function, etc., is integrated into this score. So basically, the diagnostic part stayed the same. Infection is a key element, and it changed from an inflammation to more of a risk of mortality kind of definition. And this is what is currently used in many, many studies if sepsis is investigated. Now, as I mentioned, the outcome of sepsis and the course of sepsis is very heterogeneous, and this is due to the fact that we are not only dealing with a disease which is determined by the patient itself, we also have a pathogen, a causing pathogen, bacteria. They, as you can imagine, they are very, very diverse. You have tons of different virulence factors and resistance mechanisms which can counteract, for example, treatments. The timing is also a very crucial element. At what time point does the patient present with sepsis? And rapid diagnostic is really key, and this is a 10-year-old study, but nevertheless it's shown in every sepsis presentation you're going to see. Basically, this shows the fraction of total patient, and here you have time of hypotension, so that's a shock. And you can see here that the survival fraction significantly drops if an effective antibiotic antimicrobial treatment is initiated very late. So time to diagnosis and to know what basically your pathogen enemy is absolutely crucial. And this is just a study from Basel. I would like to show you where we address that. So we used a new way of how we identify bacteria, and this is called Multitoph mass spectrometry. And we did not use that from single colonies from a culture plate, but directly from a positive blood culture. And you can see here these two lines. This is a conventional identification method, and this is this fast way of mass spectrometry directly from a blood culture. And the time to identification was significantly cut short. So we were 24 hours faster in identifying the pathogen. And mass spectrometry only provides you with the information on what pathogen it is. It doesn't tell you if the pathogen is resistant or not. So the susceptibility, classical phenotypic determination of antibiotic susceptibility stayed the same. Now, does the information on the pathogen itself has an impact on the patient? Yes, it does, but not for every pathogen. And this you can see here on the right graph. So basically, you have two groups of pathogens. The, let's say, less difficult ones in Switzerland, at least, because they are often very sensitive, are E. coli and Klebsiella. And these are the lines here. So here it doesn't matter if you know if it's an E. coli or Klebsiella, but on the top part, you can see this is a subgroup of pathogens where the identification provides you with information on intrinsic resistance mechanism a pathogen has. So it can, for example, just all the pathogens of that type express a resistance mechanism. And if you know what pathogen it is, you know also the resistance, and then you would change something. And you can see here, this is the Multitoph line, and this is the conventional line, how the curves diverge, and this is associated with a more optimal treatment. So the information on the pathogen helps you to optimize the treatment. And the impact of that was, as I mentioned, we knew 24 hours earlier what pathogen it is. We optimized the treatment, and we could reduce the mortality in that study from 70% to 8%. And this is now introduced in our routine diagnostics, so every positive blood culture flasks actually gets this type of identification at the university hospital. So, as you can see, there are many factors why we are motivated to do a sepsis study. I think a key element of this, as you have heard in the last session, a key element of the SPHN is to collect data and to bring centers together. And here we really feel that the extraction and integration of complex data sets from those patients with a sepsis may actually help to better understand the complexity of those patients, maybe to also develop new biomarkers, and I will tell you more about that, to also understand which physiological compartments and time points you would need to explore. Because you can imagine all those fancy omics technologies, they're very, very expensive. And if you knew which sample, if you need to take a look into the urine or the serum or in the lung, what is the most interesting physiological compartment, that's a very crucial point in diagnostics. To also improve the outcome, obviously, so to recognize sepsis at an earlier time point and to reduce the mortality. And I think a big issue is the interoperability of data, so that when we talk about the glucose level in Basel, it's the same in Zurich, and that's a major challenge, as you can imagine. The ontologies, we are now discussing how do we define certain disease entities. And at the end, we want to not stop this after the funding period is over. I think this should really build a framework for personalized diagnostic, but also therapeutic research in the field of sepsis. So if we now can well coordinate with all the centers, and maybe we can once do a randomized control trial or some other trials in the therapeutic field. So here you can see the different people involved. As I mentioned, Zurich, Basel, Bern, Lausanne, and Geneva involved with the ICUs, the infectious diseases, clinical microbiology. And then from the ETH, we bring in a lot of additional expertise on machine learning. So we have 2 machine learning groups, Karsten Borgward and Gunnar Rech. And we also have statisticians involved who help us to later on explore the data with fancy algorithms which are currently developed. So this is how we want to set up this project. So it's SPHN stands for the Swiss Personalized Health Network component, and that basically supports the integration of the data from the hospital. So you can see here as a symbol each hospital. We have intensive care unit which will provide data. We have laboratory tests. We have clinical information system, maybe other data from radiology, pathology, and this data will go into a data warehouse in each center. So it's not centralized, it's really in each hospital. And then the Biomed IT, the Data Coordination Center, actually helps us that these centers can communicate with each other and exchange the data. And then we have here on the lower part the ETH funded element, PHRT, that's the ETH domain. Mainly they will do machine learning with the data we provide, but on the other hand, they also have put in a lot of money for omics technologies, and I will tell you later on more what we want to do there. So the goals of the SPHN part is to build an infrastructure framework to connect the Swiss university hospitals, in particular intensive care units. And you can imagine an intensive care unit has different type of data. So it's often not a single time point, but you have continuous data of a short, in a very short time period. You have these densely monitored patients which provide a lot of information. And this is a challenge to actually capture this kind of continuous data and also to analyze it. And then we certainly have all the other clinics I mentioned. Then another critical part is the ethical and governance standards. So who can access the data? How do we do the consenting, etc.? So we have a lot of discussion with that. And there we get also a lot of help from the clinical trial unit. And then the complex clinical data sets, they will be harmonized in terms of interoperability and comparability. So those are the goals. And how do we do that? We have different work packages for this over the next 3 years, and we are now half a year in the project. So one part is to define the ethical framework and the governance structure. Then we did a very profound requirement analysis. So we identified over 500 variables we would like to collect. So this we also have to restructure now a bit and see how feasible it is, because when we provided that to the DCC, they were kind of shocked with 500 variables. It's a lot. So we have to set some priorities there. Then the target architecture. So what are the interfaces? What are the languages these kind of systems can communicate with? And then to also provide this data for scientific analysis. On the other hand, we have the ETH domain, and the ETH domain has somewhat different goals. I mean, certainly they also want to help us set up this framework, but they are really more interested in a more concrete research question. And here, I think an interesting aspect of them is that they want to early recognize sepsis and predict mortality. And how do they want to do that? by developing novel types of biomarkers, and they want to discover those biomarkers with machine learning. And I don't know if you've heard in this conference about digital biomarker. This is at the moment kind of a buzzword, that everything which is digital is already a biomarker. So, but the point here is these are just the classical variables you would collect from a patient. But if you integrate them in a multidimensional fashion and you build ratios you would not even imagine as a human being, then you get sort of a new variable. As an example, I could divide blood pressure by creatinine and multiply that by hemoglobin or something like that. No, something which now doesn't make sense, but perhaps it makes sense in the context of sepsis, and that would be a digital biomarker. Then classical molecular biomarkers, this would be, for example, genomics of the patient, but also genomics of the pathogen, metabolomics. And then we would like to combine these two, and this is the hybrid kind of biomarker part. Then we would like to select for certain time points and compartments, as I mentioned before, and also provide feedback. At the moment, I will tell you this later, we are at the stage where we build a pilot, and in this pilot phase, we also want to provide feedback how good the data quality is. Where are problems in terms of harmonization? Which data cannot be accessed? And each IT division of the university hospital will get this feedback back from ETH and then can improve gradually over the next couple of years their infrastructure, and then hopefully provide in 3 years very good data. So this part is also separated into work packages. We have the digital biomarker discovery. I explained to you the molecular biomarkers. Here we have Professor Zamboni from the ETH who will perform metabolomics of the host. We have immune phenotyping by a world-leading expert in sepsis, Thierry Calandra in Lausanne. Then human genomics, which you will also do. We have shotgun metagenomics and 16S metagenomics, which will be done by Gilbert Greub and Jacques Schrenzel from Lausanne and Geneva, and I will do bacterial whole genome sequencing. So basically every bacteria we will identify in these patients, we will sequence and provide this information then for machine learning approaches. And then I mentioned the hybrid biomarkers to combine these two, and here the reproducibility, so that we also try to reproduce then findings we have within this huge data set we're going to collect. So I think what we hopefully will achieve is that this will have an impact on individual patients, because I really feel at the moment the perspective of a patient with sepsis is really not good, and I think this will significantly help if we have new types of biomarkers, but it will also offer a network and a framework not just for basic and clinical research, because I also think pharmaceutical industries, diagnostic companies might have an opportunity to test their new tools. There are surprisingly a lot of diagnostic companies now investing into machine learning to analyze complex data sets. And I think this is will be a great data set to do that. I hope that we, with the Swiss quality label, that we will be the best global sepsis cohort at a certain point. That's certainly difficult to achieve. That's sure it will require a lot of work, and that we can also maintain funding over a longer time period, because as I mentioned, it would be a pity to build up the infrastructure and then in 3 years say, okay, let's jump to a next topic. This kind of work really benefits from huge data sets, and the longer we can actually collect digital data and omics data, the better it's going to be. And I think this is really a great initiative in Switzerland, because it brought together, first of all the 5 universities, but then also the different disciplines, and I think this is a great opportunity for sepsis. Now, just to see a bit currently what is the roadmap. So I mentioned that we have identified a lot of variables. We did some prioritization, so in terms of variables, this would be variables which are interesting for various other driver projects, for oncology, for example. Then B that would be just for our driver project, and C that would be for sub-projects. And we are currently coordinating these between all the universities. So what we will do this September and October, a first pilot, and that was approved by the Swiss ethics, that we can actually access patients and try that to test the infrastructure. No research question behind that, just test the infrastructure. And we will now see the different connections we have between the clinical data warehouse and Biomed IT. And I think the next critical point is to submit the full study to ethics throughout Switzerland. We have various ethical committees, and coordinate that for these two studies, digital biomarkers, which basically involves everybody on an intensive care unit, and omics biomarker study. There we will have classical inclusion criteria which a patient needs to fulfill, so that we are more targeted in terms of our approach. Now, if you have questions, if you're interested, please feel free to send me an email. These slides will be shared. Also in the documents of the conference. And I would really like to thank my colleagues who participate here a lot. Here you basically have from every single individual the email address. If you just want to contact somebody from Lausanne, please do so. But I'm also happy to generate this connection. Thank you very much for your attention, and I'm happy to take questions, or maybe questions are later.
Adrian, for this very enlightening overview of where the sepsis project stands. We have time for some questions.
Yeah, I have a question regarding one biomarker that actually receives a lot of attention, pancreatic stone protein. Is it something that is already integrated in the diagnosis of sepsis? Not yet.
No. Please write me an email. Write me an email. I think that would be very interesting. If you have particular biomarkers you think we should include them, I'm very happy to do that. The thing is, the digital biomarker part contains everything which we will anyways collect. And in the omics part, there we will also look for new metabolic markers. It could be, if this is in the serum, something we could measure, then most likely we might determine that with the metabolomic part.
Just, this is not a question, so please, can you put back the address of all your colleagues?
Yes, so if this works. Yes.
One slide.
Yes, somebody will do from...
Okay, thank you.
Other questions?
You mentioned the very high cost of sepsis, and there are a lot of publications, but the ones I know are from the early 2000s. Do you have any actual data from Switzerland? How much is the day cost of a patient in a...
It's probably around 10,000 Swiss francs on an intensive care unit, I would say. But I guess that the cost will be around this range. In terms of, imagine there's basically a one-to-one kind of treatment. You have a nurse and a doctor being responsible for a single patient. You have all the lab values, so these patients get several times per day a full kind of screen of their blood and microbiological examinations. I think it's really, really tremendously expensive.
There's no more questions, so thanks, Adrian, again.
Thank you very much.
Thank you.